So friends, let us come to the topic of carcinoma larynx. And whenever I start this topic, it brings a lot of satisfactory smile on the faces of the students, because this is one of the last topics for larynx, and larynx usually is the last topic of ENT. So this marks the end of our whole the lecture series in ENT, right? Okay, so let's start with the topic of carcinoma larynx. Now, CA larynx. CA larynx is generally seen in males. You see, for most of the head and neck carcinomas, the males are more commonly affected. Okay, and what age group? Age group is 50 to 60 years age group, right? The most common type of CA larynx is squamous cell carcinoma. In approximately more than 95% cases, they have squamous cell carcinoma, right? Now, you remember the larynx, we can divide the larynx into three parts. Which three parts? The larynx is divided into supraglottis, glottis, and subglottis. Okay, supraglottis, glottis, and subglottis. Therefore, the CA larynx can also be divided into three sides: the supraglottis, glottis, and subglottis. Okay, so we have CA glottis, CA supraglottis, CA subglottis. Now, which site is the most common site? So remember, CA glottis is the most common site. Okay, this is the most common site for CA larynx, CA glottis. Right? Now, let us first discuss the risk factors for developing CA larynx. Okay, so risk factors for developing CA larynx, the number one risk factor is smoking. So we all know that smoking causes carcinoma, also the carcinoma larynx other than the lung carcinoma. Now, CA larynx with smoking, the relative risk is 3.4. That means a smoker has 3.4 times higher chances of having CA larynx as compared to normal population. Okay, then alcohols. With alcohols, the relative risk is 6. That means 6 times higher chances of having CA larynx. Okay, now both smoking and alcohol, the relative risk is 15. So 15 times higher chances of having CA larynx, a person who both smokes and drinks alcohol. Okay, remember, these are not additive relative risk, they are multiplicative. Okay, so they have a multiplicative effect. So you can see that if both of them are consumed, so the relative risk is 15. Okay, now over here we can also discuss the risk factors for all the head and neck cancers. So we have discussed all the head and neck cancers. We have discussed the nasal cancer, the nasopharyngeal. We have seen the hypopharyngeal cancer. Now we are seeing the larynx. So, let's discuss the risk factor for all these head and neck cancers. Right? Number one is tobacco. So this is one of the biggest risk factors, tobacco consumption in the form of chewing tobacco or smoking. Right? So this is one of the biggest contributors for head and neck cancer. Number two is alcohol. As we just saw, alcohol also increases the risk for head and neck cancer. Number three is prolonged sun exposure. So this we studied in case of nose, basal cell carcinoma on the face, on the nose. So remember, prolonged sun exposure, ultraviolet B rays, and because of these ultraviolet B rays, we develop basal cell carcinoma rodent ulcer. Okay. Number four was viruses. So viruses, they have a tendency to cause the head and neck cancer. So we discussed about the HPV. Remember, the laryngeal papilloma can lead to development of squamous cell carcinoma. Okay, so HPV we have discussed. Epstein-Barr virus we have discussed in the carcinoma of the nasopharynx. So there also we have these viruses, they can cause cancer. Next is gender. Head and neck cancer, as we know, is more common in males compared to females, and it can be attributed to these factors also, but yes, it is more common in males. Then the age, we have the age group of more than 40 years, which is more prone to develop these head and neck cancers. Remember, I told you about CA nasopharynx. It has two peaks, bimodal age distribution. First peak, a small peak, is in 10 to 20. The second peak in 60 to 70 year age group. But yes, mostly the cancers are more common in the elder age group. Okay, then the oral or dental hygiene is also important. People who chew a lot of betel nut, the dental hygiene goes bad. So in then there is a development of oral carcinoma. Okay, oral cavity, tongue cancer, buccal mucosa cancer. So that is very common in people who chew a lot of betel nuts. Right? Then there can be environmental or occupational hazards. What are the environmental or occupational hazards? You remember we discussed about the wood industry, furniture industry. So adenocarcinoma is more common, adenocarcinoma of the nose is more common in people who are working in furniture industry or wood industry. Similarly, nickel industry, squamous cell carcinoma is more common in them. So that also we discuss in the nose. Then finally we have poor nutrition. So in the post-cricoid carcinoma, we discussed iron deficiency. Okay. So remember, iron deficiency is more common in females, that leads to Plummer-Vinson syndrome and then leads to post-cricoid carcinoma. Similarly, vitamin A and vitamin B deficiency are also associated with risk for head and neck cancer. Okay, and this question was asked recently in the AIMS May 19 exam. Which of the following is not a cause for squamous cell carcinoma for head and neck region? Okay, so which of the following is not a cause? Let's look over here. Epstein-Barr virus, we just saw it's a cause. It's a cause in CA nasopharynx. Human papilloma virus is the cause. It can cause carcinoma larynx. We know the papilloma, the laryngeal papilloma, they can convert into squamous cell carcinoma of the larynx. Then the betel nut consumption causes oral cavity cancers. Okay, and then vitamin A. Now you see, this was a trick question. Remember I said vitamin A deficiency causes squamous cell carcinoma. Okay, vitamin A itself will prevent the carcinoma, but its deficiency causes squamous cell carcinoma. So it was a trick question and the vitamin A is the answer. It is not a cause for squamous cell carcinoma. Its deficiency is a cause for squamous cell carcinoma. Right? Okay, now let's come back to CA larynx. So we discussed the most common site is CA glottis. Okay, so the next question is, what is the most common presentation for CA glottis? The most common presentation of CA glottis is hoarseness. Remember, anything on the vocal fold, it produces hoarseness. The voice becomes rough, coarse, hollow. Right? So most common presentation of CA glottis is hoarseness. Once again, now what is the most common presentation of CA supraglottis? So what is there in the supraglottis? Supraglottis, we have the interlaryngeal nerve, and that function is to detect the foreign body. Any foreign body tries to goes inside the airway, it produces a cough reflex. So anything on the supraglottis, it will cause a foreign body sensation in throat. Right? And what about CA subglottis? So remember, CA subglottis does not have any structure. So any malignancy or a tumor or any mass in subglottis, it has only one way of presenting, by blocking the airway and thus causing stridor. Okay, now because CA subglottis presents with stridor and there is no other structure, it usually presents late, and therefore because of this late presentation, it has poor prognosis. Okay, so CA subglottis has a poor prognosis. Now because of the hoarseness, okay, because of hoarseness, CA glottis presents early. Also in CA glottis, the lymphatic drainage is very less. So the lymphatic spread from CA glottis is late because of less lymphatics in CA glottis. Okay, in the glottis area, the lymphatics are less. Therefore, lymphatic spread is late. But the presentation is very early. So we will have a late metastasis and an early presentation. So out of the three, you see the best prognosis. The best prognosis of CA larynx is seen in CA glottis. Okay, this is where we see the best prognosis. Right? Okay, so we have discussed the presentation. The presentation for CA glottis we know now is hoarseness. Okay, that's the most common presentation, but we can also have blockage of the airway, respiratory distress. If the patient does not come early, the mass will grow and will present to us with even stridor also sometimes. Okay, now let us do the staging for CA glottis. So let's first do the staging for CA glottis. Okay, so we have diagnosed a case of CA glottis. Patient presented to us with hoarseness. We did a laryngoscopy. On laryngoscopy, we saw a mass. Okay, we saw a mass over here. All right, so now we have a case of a suspected malignancy of the larynx. How will we confirm it? We can do a biopsy. Right, so we do a biopsy. Which biopsy will you do? To do a biopsy, you have to do direct laryngoscopy. Right? To do a biopsy, to do direct laryngoscopy. And direct laryngoscopic biopsy, it will confirm your diagnosis of malignancy, that it is a carcinoma. Right? So direct laryngoscopic biopsy is the investigation of choice. This is the investigation of choice for CA larynx, whether it is supraglottis or glottis or subglottis. This is the investigation of choice. Right? Now, how will you stage this disease? Okay, how will you stage this malignancy? So the staging is the TNM staging once again. Right? N and M are common, and I've already taught you N and M are common for all the endemic malignancies except CA nasopharynx. So in the nasopharynx topic, I have already taught you N and M. Right? Let's do the T staging. Right? So let's do the T staging for CA glottis. Now, T staging for CA glottis, it's very easy to understand. There are two vocal folds. Okay, so on two vocal folds, there can be malignancy. So let's say the malignancy is like this on one vocal fold over here. Okay, now from here, this malignancy, it can grow. How can it grow? It can grow and it can involve the anterior commissure. Right? Okay, it will still be T1. So it is on one fold, it is T1. Okay, it can go to the other fold. From the anterior commissure, it can go to the other fold like this. It will still be T1. Okay, it can grow. Let's say it does not go to the anterior commissure. Okay, instead it grows and it goes to the posterior commissure. Okay, it goes to the posterior commissure, it will still be T1. Right, now from the posterior commissure, let's say it goes to the other vocal fold, it will still be T1. Right, so what is T1? T1 means one fold or both the folds. Okay, so one fold or both the folds, it does not make a difference. Okay, whether there is anterior commissure involvement or there is posterior commissure involvement, that also does not make a difference. So what is making difference? The difference is made by vocal fold mobility. Okay, vocal fold mobility, and there should be completely free vocal fold mobility. If there is a free vocal fold mobility, look at my fingers, two vocal fold, they are moving freely completely, then it is a T1 lesion. Okay, so T1 lesion clearly means only one thing for us, that is your free vocal fold mobility. Right? Now we can divide T1 into T1A and T1B. T1A and T1B. So how do we divide into T1A and T1B? T1A means one vocal fold. If the malignancy is on one vocal fold, it is T1A. If it involves both the vocal folds, it will be T1B. Okay, so like this is T1A. If it grows and goes to the other vocal fold, it will be T1B. Right? Okay, now let's come to T2. Let's come to T2. So what do we mean by T2? T2, you look in the second photograph, what do you see? The malignancy size has increased. Okay, now because the size has increased, what happens? It is not allowing the vocal fold to move freely. The vocal fold is not able to move completely. So T2 means impaired mobility. Okay, impaired vocal fold mobility. So instead of the word impaired, I can even use the word restricted vocal fold mobility. Okay, or I can even use the word incomplete vocal fold mobility. All of these three words mean the same thing, right? So that's a restricted or impaired or incomplete vocal fold mobility. That is your stage 2, right? Stage 3. What do I mean by T3 stage? Now you see the T3 stage, let's say this malignancy leads to fixation of vocal fold. Size is same, but it has penetrated deep, and then now the vocal fold is not able to move completely. So then we will call it as T3 stage. So T3 stage is vocal fold fixed. Any vocal fold, okay? Even if one vocal fold is fixed, it will be T3. Any vocal fold impaired, it will be T2. Okay, so vocal fold fixed, no mobility at all, it will be T3, right? Okay, so let's look in this diagram, and we can see over here we have the T1. So what was T1? One fold or both fold, but both are freely mobile, right? T2, what was T2? T2 was impaired mobility. Maybe it involves the supraglottis or subglottis, okay, but impaired mobility. T3, vocal fold is fixed. You see, this fold is fixed over here, not mobile at all, okay? And T4, what is T4? It goes outside larynx. So T4 means it goes outside larynx into the neck. So outside larynx into the neck, it is T4. Now this T4, remember we discussed the CA hypopharynx, there we discussed this T4, and it is common for larynx and hypopharynx. You can divide T4 into T4A and T4B. Okay, now what is T4B? I have told you there also T4B, 3 places. What are the 3 places when we call as T4B? Number 1, superior mediastinum. Number 2, prevertebral space. And number 3, it encases the carotid artery. Okay, so 3 places where you called as T4B. Number 1 is superior mediastinum. So if the malignancy goes into superior mediastinum, number 2, it goes into prevertebral space, and number 3, it encases carotid artery. In all these 3 situations, the disease becomes incurable, right? And therefore it is classified as T4B. Anywhere else in the neck, it is known as T4A. Okay, suppose it is involving the strap muscles, the sternocleidomastoid muscle, the thyroid gland, so all that will be T4A. So other than these 3 places, it is T4A, right? So that's the staging for CA glottis. Okay, now let's do the treatment also over here. Let's do the treatment for CA glottis, right? Treatment for CA glottis. Now treatment for CA glottis will depend upon the T stage, right? So treatment depends upon T stage. Also, treatment depends our desire to save the larynx, because larynx is an important organ. The larynx we want to save because it provides us the voice. Okay, patient wants to speak. Also, it's a airway. So there is a airway, there is a passage over here in the airway, and this acts as a guardian. So if we just remove the larynx, we cannot connect the trachea directly to the esophagus. Okay, so if we need that airway where the larynx acts as a guardian, we would like to save the larynx. So T1 and T2 stage, you see the vocal fold is still, some mobility is there in T2 also. So we want to save the larynx, right? We don't want to destroy its function. It has very unique functions. So what we will do is we will give radiotherapy. Okay, so T1 and T2 stages, the treatment of choice is radiotherapy. Why? Because this saves the larynx for us. Okay, T1 and T2 we do radiotherapy. Now let's look over here. Let's look over here in this photograph. Okay, this was a T1A lesion. Okay, we can understand now it's a small lesion on one vocal fold. So this is a T1A lesion, right? Now what will you do for this? There is one more treatment. One is radiotherapy. Okay, the other treatment which is possible for this patient, and that is laser cordectomy. Okay, so that treatment is laser cordectomy. So what we do in laser cordectomy, we will cut and remove this much part of the vocal fold along with the malignancy, and the patient is cured. Right? Now the advantage of laser cordectomy is it's a single sitting. In single sitting, in one day you remove it, patient can go back. That is a big advantage. For radiotherapy, the patient has to visit the hospital for around 6 to 7 weeks. Right? But remember, the cure rate of radiotherapy and laser cordectomy are same. The cure rate are same. So what is the disadvantage of radiotherapy? Patient has to have multiple visits, 6 to 7 weeks. So 1.5 months he is coming to the hospital. Cordectomy, it has advantage, single day you can remove it. What is the disadvantage of cordectomy? In cordectomy, generally the voice is poor because you are cutting the vocal fold. So voice is poor compared to the voice we get in radiotherapy. After the radiotherapy, the voice is better. Right? So it is the choice of the patient. Remember, so when we have a T1A lesion, there are two treatment options. One is radiotherapy and one is laser cordectomy. So we give the choice to the patient, and whichever the patient chooses, that we will do the treatment. Both treatments are all right. Okay, both can be considered as treatment of choices because both have equal good cure rate, both have their advantage and disadvantages. Right? So if this question comes in your exam, what answer you have marked? Now, so what answers you have to mark? Remember one thing. If the examiner is giving you a very clear-cut question where the examiner has mentioned you this much size of the malignancy on one vocal fold, or he has given you a diagram like this, right? And the options has laser cordectomy. So he wants you to answer the laser cordectomy. Okay, right? If the laser cordectomy is there in the choices, right, and the examiner has mentioned that only one fold is involved, there is free mobility, he has specified it's a T1A lesion, it's a small lesion, not involving anterior commissure or posterior commissure, okay, so you can mark your answer as laser cordectomy. Right? Okay, if the size is not mentioned, no image is given to you, you are not sure whether anterior or posterior commissure are involved, okay, then radiotherapy is the answer because it's a universal answer for T1 lesion and T2 lesion. Right? Okay, now T3 lesion. Let's come to the T3 lesion. Okay, what treatment will you give for T3? Now in T3, the vocal fold is fixed. So earlier what we used to do was we used to think that the larynx function is now gone, so let's do a total laryngectomy. So this was the treatment of choice in older days. Okay, so this was the old treatment of choice. But nowadays, we know even if one fold is gone, it is completely paralyzed, the other is mobile. We still want to save this function. Okay, we still want to save some airway. Right? And not only airway, it will also provide a good voice. Right? So laryngeal preservation, and now we have good radiotherapy techniques, we have good chemotherapy medicines. So now CCRT, concurrent chemoradiotherapy, this is the new treatment of choice for carcinoma glottis. Okay, this is the new treatment of choice because it will preserve the voice of the patient. Okay, this has equally good results as compared to total laryngectomy. So T3, we do give CCRT as the treatment of choice. Now, when we will not give CCRT in T3, now remember, CCRT, concurrent chemoradiotherapy, is not given if there is perichondritis. Okay, so remember perichondritis, or the question says there is cartilage erosion. So there is an invasion into the cartilage, or there is an invasion into the cartilage. So erosion will happen only when there is invasion. Okay, so there is cartilage erosion or invasion, or there is perichondritis. So perichondritis also represents that malignancy has now almost gone into the cartilage. Okay, this is a absolute contraindication to radiotherapy. That means you have to go and do surgery. right? So if there is perichondritis, there is cartilage erosion or invasion, you have to do total laryngectomy. It's an absolute contraindication to radiotherapy. Clear? Okay. Now another contraindication may be a high volume tumor, because radiotherapy is useful when the tumor volume is low. So if it's a high volume, more than 20 ml, okay, that we can analyze by doing a volumetric analysis of the CT scan or the MRI. And if it is more than 20 ml, then we will go and do surgery, right? Radiotherapy will not be effective. Okay, now let's come to the T4 stage. So T4, we have T4A and T4B. Okay, so T4A stage, the malignancy has grown outside larynx. Okay, so you have to do total laryngectomy. Usually it has eroded the cartilage, so you cannot do radiotherapy. You have to do laryngectomy. But even after doing laryngectomy, some malignancy may be left behind, so you have to give radiotherapy also. Okay, so take out some malignancy which was left in the neck, plus minus sometimes you may do CT also, chemotherapy also. So combined modality is the treatment of choice for T4A lesion. Now T4B lesions, these lesions are generally incurable lesions. You cannot cure these lesions. Okay, these conditions, when the malignancy has spread too much, the patient is already debilitated, the general health is poor, all right, or even if you do a big surgery, a radical surgery, you will not be able to take out the disease in entirety. Okay, so what we do is we do a palliative therapy for the patient. Okay, so palliative therapy means a lot of things. It means number one is the pain relief. Number two, we have created an airway. If the malignancy is blocking the digestive pathway, you create alternates for digestive pathway. Okay, such as you can do a feeding gastrostomy or a feeding gynostomy to give the food to the patient. All right, so these are palliative methods to improve the last few days of the patient life. So that is generally done for T4B lesions, right? Okay, now before I go ahead, let me just tell you one small thing. What was the one small thing? You see, if there is a malignancy, let's say there is a malignancy over here in the anterior commissure area. Okay, so we have a small malignancy in the anterior commissure area. Both the vocal folds are freely mobile. So what stage we will call it? We will call it the T1 stage. Right? On the anterior commissure, both vocal folds are freely mobile. It's a T1 stage. Now, this anterior commissure area, this is a very important area because it is a blind area in the indirect laryngoscopy. It is not very clearly visible. And if this malignancy grows, it spreads, it will quickly involve the perichondrium of thyroid cartilage. Okay, it will quickly involve the perichondrium of thyroid cartilage. Then it can involve the thyroid cartilage and it can go to the neck, anterior neck, right? So this malignancy very quickly become from T1 to T4A. Okay, and in this anterior commissure area, we usually do not like to do radiotherapy because most commonly it has already involved the perichondrium. So there is already a perichondritis and that is a contraindication for radiotherapy. So remember, T1 lesion of anterior commissure. Anterior commissure is such a place that malignancy is T1, but we will treat this malignancy as T4A. That means you will do total laryngectomy in these cases. Okay, so if there is a malignancy of anterior commissure, that's a special place in the glottis. All right, so in this special place, even if there is both the vocal folds are mobile, this T1 lesion will be treated as T4A lesion. All right, okay, so that was something special about anterior commissure. Now let us come to the CA supraglottis. Okay, let's come to CA supraglottis. So let's do the T staging for CA supraglottis. Okay, so T staging, once again we can divide into T1, 2, 3 and 4. Okay, now T1 means any one subsite. Remember, I told you there are 5 subsites for CA supraglottis. So what are the 5 subsites for CA supraglottis? So remember, the 5 subsites for CA supraglottis are suprahyoid epiglottis. Number 2, we have infrahyoid epiglottis. Number 3, we have the pair of arytenoid cartilages. Okay, we have the pair, one on each side of the epiglottic folds, AE folds. And number 5, we have a pair of vestibular or ventricular folds. So these are the 5 subsites. So any one subsite is T1. Okay, now more than one subsite. So if I talk about T2, T2 means more than one subsite. Okay, more than one subsite, that is T2. Or the malignancy goes, suppose there is a suprahyoid malignancy, suprahyoid epiglottic malignancy, and it goes and involves the mucosa of tongue base. So remember, mucosa of tongue base, you will say it is T2. But somebody says the muscle of tongue base, that will be T4A. It is outside larynx. Because mucosa is continuous with the epiglottis, you can still say mucosa of tongue base is T2, right? But if it's muscle of tongue base, it will be T4A lesion, right? What is T3 in supraglottis? T3 in supraglottis is if it goes to the glottis and the vocal fold becomes fixed. Okay, vocal fold is fixed, it is T3. And other than this, the malignancy can be in the 3P spaces. What is 3P space? The 3P space over here for supraglottis, the 3P space is the pre-epiglottic space. So we have discussed anterior to epiglottis, we have pre-epiglottic space of Boyer, right? Or it can be in the paraglottic space. So paraglottic space, again I have told you, if malignancy is there in the paraglottic space of Tucker, it is considered as a transglottic malignancy and we call it as T3. Or the malignancy is in the post-cricoid area. Okay, malignancy is in the post-cricoid area. So any of these 3 places, it will be considered as a T3 stage. Okay, so T3 vocal fold fixed or it is in 3P. Okay, T4 is common. T4 is common for CA supraglottis, glottis and subglottis. So again we have T4A and we have T4B. Right? So that is common for all the 3 sites. Alright, so this was the CA supraglottic staging, right? Okay, now let us discuss this question over here. You see, this is the mass. So identify this mass. Where is the mass? Alright, now let's look carefully in this photograph and what do we see? This is the epiglottis over here, right? And what can we see? We can see the vestibular fold over here, also known as false vocal cord. So on the left side you can see, but on this side, this all is covered with this ulcerative mass. Okay, so this is supraglottic carcinoma, right? The vocal fold of the left side is visible, on the right side it is not visible. Now, to call it staging, we have to know whether the vocal fold is fixed or mobile, right? As it appears, the other fold is not visible, and when the patient tries to do the adduction, if this fold does not become visible, that means it will be a T3 stage at least with the vocal fold fixed. If it has gone outside the larynx, it may even be T4 stage, right? Okay, let's come to the TNM staging for CA subglottis. Now, CA subglottis, remember, it presents late. There is no structure. Okay, it presents late. So ideally, the T1 and the T2 stage is not seen. Okay, subglottis T1 and T2 stages are not seen. Why they are not seen? Because the patient does not present in these stages. These are silent stages. Okay, so T1 malignancy is in subglottis, right? There is no symptom, so you will not detect. T2 malignancy comes to glottis, but the vocal fold is yet not fixed. Okay, right? So sometime you may have hoarseness, right, because of glottis involvement, but then you cannot know whether it is glottic carcinoma or it is subglottic carcinoma. You don't know whether the malignancy has gone from above to below or from below to above, right? Now, T3 and T4 for CS subglottis is same as glottis. Okay, they are same. So T3 vocal fold fixed, that is your T3. T4 it goes outside larynx, right? So that is your T4. So CA subglottis and CA glottis, T3 and T4 staging is absolutely same. T1 and T2 usually does not present in CA subglottis. Okay, right. So these were the TNM staging, and we have already discussed the treatment. We have to remember the treatment only for CA glottis, and that's what I have discussed over here. CA subglottis, you see, does not present in T1 and T2 stages. All right. So obviously, because it does not present, we don't have any special treatment, right? T3 is same as glottis, so treatment will be CCRT. Okay, but subglottis usually has a lot of spread to the neck nodes. If the neck nodes are also present, unlike the glottis, the neck node involvement is early in CA subglottis. So if the neck nodes are also present in T3 of subglottis, then you may have to directly go for surgery. Okay, because neck nodes also need treatment. T4 of course needs surgery, right? Okay, so that was the CA subglottis. Now CA supraglottis. CA supraglottis, T1 lesion you can treat by radiotherapy. Single site lesion you treat by radiotherapy. Again, CA supraglottis has a high lymphatic supply, so therefore the neck node involvement is early. So by T2 stage you will see that there is some neck node involvement, right? So T2 stage will require surgery. All right, so in T2 stage, but you don't want to remove the whole larynx, so we prefer partial laryngectomy. Okay, so we prefer partial laryngectomy in T2 phase along with the neck dissection if there is lymph node present, right? The T3 stage of CA supraglottis will require once again surgery, that is your total laryngectomy. Why? Because once again the neck dissection is required in T3 stage. Remember T2, if you don't require the neck dissection, okay, there is no lymph node involvement, okay, then you can even go for CCRT. Okay, so T2 supraglottis you can even choose CCRT if there is no neck dissection required, there is no neck lymph node involvement. But T3 you have to go for surgery along with neck dissection. Okay, T4 management will remain same because T4 you cannot identify it as supraglottis or glottis or subglottis. Okay, so T4A you will require combined modality, T4B is palliative treatment, right? So that was the treatment for all the three different sites of larynx. Let us come to this question. A patient presents with hoarseness of voice, right? So there is something in the larynx, hoarseness of voice. On examination, an ulceroproliferative mass is seen on the light vocal cord. Cord was hover mobile. So there is a ulceroproliferative mass. It can be a malignancy. It is seen in right vocal fold. One vocal fold is involved, but the cord is mobile, right? So it can be a T1 stage, right? There is hoarseness. Maybe if there is some restricted mobility, it can be T2. They have not mentioned fully mobile or partially mobile, but they have said mobile. We consider it as a fully mobile. So when we say mobile, we consider as a T1 stage, which there is no lymph node involvement and no metastasis. So N0, M0, right? CA glottis T1, N0, M0. Which of the following is the best treatment modality for this patient? We know the best is radiotherapy. That has to be our answer in this question. Okay, so this was asked recently in the August 2020 FMG exam, and these are the kind of questions that will now be asked in the next exam as well. Right? So clinical case scenarios, and these are the questions that you have to prepare for. Questions are simple, all right? They are little lengthy, but they are quite simple. If you read the history carefully, you can easily solve these questions. Now, another question which was asked in the Jan 2019 NEET PG exam, a 60-year-old patient presented with hoarseness of voice. So two things are important over here. 60-year-old patient presented with hoarseness of voice. So hoarseness of voice means larynx is involved. On examination, following finding is shown below. What could be the diagnosis? So you can see that there is the neck swelling. Okay, so there is a neck swelling, most likely a lymph node involvement is there. Now, there is something in the larynx and it has involved the lymph node. It is usually a case of malignancy. Okay, so malignancy involving the lymph nodes. 60-year-old male patient, history also points towards chances of malignancy. So answer can be secondary snake. Right, now this is our first DD and this is the best answer. Okay, it is by three things: hoarseness, okay, there is neck lymph node on examination, and number 3, 60 years. Right, another possible answer can be TB lymphadenitis. This is also a possible DD. Why? Because we can assume that the lymph node has involved the recurrent nerve and has caused the palsy. Maybe the lymph node has involved the recurrent, there's a recurrent nerve palsy, and that causes transient hoarseness. So we may have a similar situation where the patient has a lymphadenitis because of tuberculosis and there is a transient hoarseness. So but because first thing it's a transient hoarseness, number 2, 60-year-old male patient, it points towards malignancy. All right, so malignancy we have to keep as the first diagnosis. So secondaries of the neck over here is the most suitable answer to this question. Right, okay, next look in this patient. So what we have done, we have done a total laryngectomy. So you do the surgery, you give an incision and you total laryngectomy, and then what you do for the trachea, you stitch the trachea to the skin. This is known as permanent tracheostomy. Okay, so what is this known as? This is known as permanent tracheostomy. Now the patient breathes from the neck directly into the trachea. Right, you have created a permanent tracheostomy. To create this permanent tracheostomy, you will need as much length of trachea as possible. Okay, so this opening is known as stoma or the permanent tracheostomy, and you need as much length of the trachea as possible. Therefore, if a carcinoma larynx patient comes to you, remember, if a CA larynx patient comes to you with stridor and you think that you have to do a tracheostomy to save the airway, now after tracheostomy, sometime later, the patient will undergo total laryngectomy. Okay, so therefore, when you will do tracheostomy in CA larynx, patient may require total laryngectomy after some time. You will try to save as much trachea as possible, and therefore we do high tracheostomy. Okay, so remember I told you in CA larynx we do high tracheostomy. Why? I will tell you later. So we do high tracheostomy in CA larynx to save as much length of trachea as possible, so that we may do a permanent tracheostome formation later on after total laryngectomy. Right? Okay. Now, you have removed the larynx. You have done total laryngectomy. Now this patient wants to speak. So how will you rehabilitate a patient for voice after laryngectomy? Okay, so let's talk about rehabilitation of voice. Okay, how will you give the patient his voice back? He wants to speak, he wants to communicate with other people. The first thing that you can do is you can give this patient electrolarynx. So this electrolarynx, this is a handheld device. Patient puts it at the floor of the mouth. Okay, so you can see over here the patient applies it at the floor of the mouth, and now this gives vibration. You see, these vibrations, they go into the oropharynx, into the pharynx. From there, they vibrate the pharyngeal mucosa and a sound is created. This sound is converted into speech when the voice travels in the oropharynx, in the oral cavity, by the lips, by the tongue, by the buccal mucosa. So they convert into speech. So this is known as speech by electrolarynx. Okay. Now, this speech is very easy to generate. You have to just put the electrolarynx and you can start speaking after laryngectomy. Alright, so it is easy to generate for a patient. Now, the problem with this speech is that it is a monotonous, robotic voice. Right? So this speech is easy, but it is a robotic voice. Right? So what will you do now? The patient comes back to you. This uncle, he comes back to you and he says, I don't want a robotic voice. All right, I want a better voice. All right. So what will you do now? You can train this patient for esophageal speech. So what is this esophageal speech? Now you see over here, these patients, they have a different physiology than normal people. Why? Because their airway is separate from their digestive pathway. Okay. Now you can see there is a lot of fat over here. There is no larynx. So airway is separate. Okay. So now you can train this patient to take some air in the mouth, close the mouth and swallow the air. Where will the air go? Air can only go into the esophagus. There is no other place for the air to escape. So he'll swallow the air goes into the esophagus. So he collects the air in the esophagus. And then he pumps his chest inside. Okay. The thoracic cage, he pumps inside. The diaphragm goes up. This he has to learn by exercise. And when he pumps it inside, this air comes out with pressure. So when the air comes out with pressure, now this vibrates the pharyngeal mucosa and is converted into speech. Right? By the mouth, by the tongue, by the lips, the voice is converted into speech. So this is known as esophageal speech. What is the advantage of esophageal speech? The voice quality is good. Okay? It is not like a robotic voice. The voice is really good over here. But what is the disadvantage? Number one, the patient needs a lot of motivation to learn and practice the speech. Right? Number two, very important. Patient can take only a little bit of air. So when the patient tries to speak, he will be able to speak 1 or 2 or maximum 3 words at a time. He cannot speak a complete sentence. Okay, so this is a broken sentence speech. Broken speech. Okay, he cannot shout, he cannot take a lecture. Right? He cannot give a speech. So this speech, the esophageal speech, is a short sentence or a broken sentence speech. Okay, so this patient comes back to you. You train him for a few weeks to months for esophageal speech. Initially, he's very happy. All right, but later on, the patient will come back to you. He'll say that I want to speak freely. I want to speak loudly. I want to speak complete sentences. So he comes back to you. I want to fight with my wife. Okay, before I can even say one statement, she gives me 10 arguments. All right, so you'll teach the patient another kind of speech. Right? But you'll warn, you can never win from a fight with your wife, whatever kind of speech you may have. Okay, so now what will you do? You will give the patient tracheoesophageal speech. So what is tracheoesophageal speech? Tracheoesophageal speech uses a one-way valve. We call this valve as tracheoesophageal voice prosthesis, TEP. Okay, so this is known as TEP or tracheoesophageal voice prosthesis. Now, this is a one-way valve. It is placed between trachea and esophagus. Right? Is it placed between trachea and esophagus? So you can see the process is placed between trachea and esophagus. Now, what is the function of this prosthesis? It does not allow any food or water, any liquid to come from esophagus to trachea. It does not allow that. But it allows the air to go from trachea to esophagus. Okay, so it allows only the air. Air is allowed, but food and liquid is not allowed from esophagus to come into the trachea. It's a one-way valve. All right. So now when the patient wants to speak, what will he do? The patient takes a finger and closes the tracheostome. So patient closes the tracheostome. Now what will happen? The air starts going from trachea to esophagus. And when the air goes, it will vibrate the pharyngeal mucosa. A voice is generated, which is converted into speech in the oropharynx, oral cavity, lips, etc. So known as tracheoesophageal speech. The voice quality is good, right? So voice is good. Now, what else? The patient is using the lung capacity for air. So because the patient is using lung capacity, patient can speak like a normal person, right? He can take lectures, he can give a speech, he can shout, he can even fight. May not win the argument, but he can fight, right? So that is tracheoesophageal speech. This is the best way to rehabilitate the patient after laryngectomy for voice. Best way, right? But remember, this tracheoesophageal voice prosthesis, this needs a lot of hygiene and maintenance. Okay, we may have to change this between 6 months to 2 years time. Okay, 6 months to 2 years time, depending upon the hygiene. If you maintain a good hygiene, you can maintain it for 2 years, right? If you maintain a poor hygiene, you may have to change it every 6 months. Otherwise, the fungus will grow. There will be infection around it. It will cause a tracheoesophageal fistula. Okay, and the food will start coming to trachea. Patient will have aspiration, lot of problems. So this prosthesis is done in high socioeconomic status people, or at least those people who are able to maintain hygiene. So we will not do in low socioeconomic status people, number one. Number two, we will not do in patients who are living away from the hospital and cannot follow up, because follow-up will be required for lifelong. Okay, because anytime this starts leaking, we may have to change it. It gets infected, we may have to change it. So follow-up is required, cannot do in low socioeconomic status people, especially those people who cannot maintain hygiene, right? So this method is the best, but it's not for everyone. All right, so that is your tracheoesophageal speech. Now remember, we have electrolarynx, we have esophageal speech, we have tracheoesophageal speech. There is nothing like tracheal speech. So remember, there is nothing like tracheal speech. Okay, so this question is asked, which are the following kind of speech voice rehabilitation we cannot do after laryngectomy? So remember, there is nothing like tracheal speech. Okay, we have tracheoesophageal speech, esophageal speech, electrolarynx. Now let's look at this question. Identify the mechanism of given prosthesis used for voice production in a post-laryngectomy patient. So we have a post-laryngectomy patient. You can see the stoma over here, right? In this stoma, you can see a prosthesis over here. Okay, so that is your one-way wall, the tracheoesophageal voice prosthesis. This is TP, and the mechanism is to generate a tracheoesophageal speech. Okay, so that is our answer to this question. We generated tracheoesophageal speech. So this question was asked recently in the June 2020 AIMS exam. Answer is tracheoesophageal speech. All right, so that finishes our topic of CA larynx and the larynx as well. And those people who have already done the other parts of the ear, they have also finished the ENT. So I wish all of you the best of luck for your exams. And I would like to remind you once again that more important than completing the lectures is the number of revisions. Okay, revision is the single most criteria. This is the single most criteria to clear your exam, to score a very high rank. The number of revisions will be more important than how much course you have studied, right? So as I have said during my lectures also, revise, revise, revise. How many times you must revise? Ideal number is 10. This is the number of revisions you must do. So as to you are able to get a very good rank, your dream college, your dream branch. Okay, best of luck. Remember, if I can clear my exam, anyone can clear your exam. Okay, so any of you can clear your exam. If I cleared my exam, I was just like you. Okay, I also used to have a lot of fun during my MBBS days, but then when you start preparing, you have to focus on revision. Okay, so best of luck. Thank you very much.